Hey Bella, how are you?
Good, how are you?
I'm doing well. So let's get started here. I'm going to be recording so that we can share this so you guys can look at it a little bit later on. If you need to, give me just a second and we'll get this party started here. Let's see, share the screen. How's your morning going?
It's hard.
You sound, it doesn't sound good.
Yeah, I'm just tired.
Oh, I bet you are. So are you able to see kind of the red and white slides?
Yeah, I can.
All right, so we'll get started here. Looks like Alexis is coming in, so that's good. So, when evaluating an arterial blood gas in the post resuscitation phase, breaths per minute should be titrated to achieve a partial pressure of carbon dioxide at what value? 45 to 55 millimeters of mercury, 40 to 50, 35 to 45, or 30 to 40. Now, which one of those do you feel like would be the best answer?
35 to 45.
Yeah, because that's basically normal as far as we're looking at here. And again, we don't want the patient to be too acidotic. Neither do we want them to be alkalotic because now gas exchange is going to be negatively impacted as far as that goes. Now, one of the things to keep in mind as far as both of your practical part of your mega code as well as in the written exam is the questions, particularly in your written exam, your questions are not going to be nearly as difficult as what you could expect to see on your registry exam. You've already taken your registry for EMT, so you kind of know how those are structured, and you also kind of know how I structure my exams as well. But with ACLS, they're not nearly as difficult, but these are all ones that are going to be joining in there. So morning, Alexis. How are you?
I'm good. How are you?
All right. So this one is your question. Okay. When using a monophasic defibrillator for ventricular fibrillation, pulsus vitae, what's the appropriate level of joules for the first and subsequently delivered shocks? 200 joules, 260 joules, 360 joules, or 300 joules? Which one of those do you think is the best answer? Again, remember we're using a monophasic defibrillator.
Wouldn't that be 360?
That would exactly be 360. So basically, what we're doing with a monophasic defibrillator is that we go with full power. In the dark ages, we used to do stair stack shocks. We would go 200, 300, and then 360. And occasionally we have defibrillators that would go up to 400. And we would add that in there as well. But with this one, basically what we're looking at with a monophasic defibrillator, we want to go with a full power setting, and we will continue that the best. So, Alexis, uh, you become the teacher. Tell me what's the difference between a monophasic and a biphasic defibrillator.
Isn't it just the way that the shock is delivered, like the way it travels?
Yeah, perfect. So, monophasic defibrillator goes in one direction. Okay, so it goes from here to here. A biphasic defibrillation does this, and then it comes back up to the top, and it does it almost instantaneously. So the benefits of that is that it's a more effective delivery of electricity, and we can use a lower energy setting. Very, very good. All right, Bella, this one's yours. Once IVIO access has been established, which of the following should be administered in a patient with confirmed PEA or asystole? Atropine, 1 milligram, adenosine, 6 milligrams, epi, 1 milligram, or amiodarone, 150 milligrams.
Epinephrine, 1 milligram.
Yeah, and what's the concentration that we're going to utilize for that epi?
1 to 10,000.
Yep. PEA asystole is actually, in my opinion, probably the easiest algorithm that you're working with for a couple of reasons. Number one, basically it's CPR, epi, and reversible causes. Okay, so be sure that you know what those reversible causes would be. The most pertinent ones that would be in regards to what your scenario is. So, for example, let's say that you are dealing with gunshot wound to the chest with a tension pneumothorax. We know that a tension pneumothorax can cause PEA. It's highly unlikely, although not out of the realm of possibility, that hypothermia would be one of your reversible causes. Now it could be, but especially if your setting takes place in like July in the South. And so with that PEA assistly algorithm, CPR, assistly, and reversible causes, very good. All right, Alexis, during CPR, after an advanced airway is in place, which of the following is true? The breath should be synchronized with the chest compressions. B, the goal is 20 or greater breaths per minute. C, chest compressions should be stopped while giving breaths. Or D, one breath every 6 seconds should be given.
The one breath every 6 seconds.
Outstanding. Yes, very, very much so. So, Alexis, when we're looking at ventilating our patients, what is the danger of hyperventilation from both a rate and a tidal volume perspective?
Well, if you hyperventilate them, you can cause like the gastric dissension, or you could increase the risk of vomiting, which would lead to aspiration.
Good, very, very good. So we increase the risk of aspiration. We put pressure on the heart, which again, if it's in cardiac arrest, we're not so much worried about pressure on the vagus nerve as much as we would be within this particular situation of the heart not being allowed to expand fully to allow for adequate preload. Okay. And the other thing is, if we're hyperventilating at a fast rate, remember we're going to blow that CO2 off, and it's going to make much more difficult for the arterial system to work. Good, good. Bella, what 3 medications are recommended for the treatment of hypotension in the post-resuscitation phase? Sotalol, dopamine, or amiodarone, epinephrine, norepinephrine, dopamine, norepinephrine, amiodarone, and sotalol, or epinephrine, sotalol, and labetalol.
B.
Perfect. Yeah. So these are all vasoconstrictive agents. Okay. Sotalol is what? Bella, what is sotalol?
I'm not sure. I just know it's not a pressor.
Okay. Let's take a look here at.
Oh, it's a beta blocker.
There you go. Hey, Youssef, welcome. Glad you're here. Okay, same way with labetalol. So the last thing we want to give a patient that has hypotension after we've gotten ROSC is any type of thing that's going to slow down the heart rate. So beta blockers are going to be completely out. Beta blockers are great for patients who are in the process of having heart attacks, and for some agencies, they're actually doing that. I think Montgomery County and maybe Georgetown is also doing that as part of their protocols. But again, epi, norepi, and dopamine are the ones that we're going to be. So, Youssef, we're just going question to question, and I'm bouncing it off each one of the folks that are attending. So I'll go to Alexis, and then Youssef, you'll be after Alexis. If a patient is taking dipyramol or carbamazepine, the initial dose of adenosine should be reduced to how many milligrams? 4 milligrams, 3 milligrams, 5 milligrams, or 2 milligrams?
Would it be the 3 milligrams?
Now, let me ask you a question, Alexis. Did you know that, or was that a good guess? Because you got it right.
I mean, I thought I remembered reading that you would just have to cut it in half, so 3 milligrams.
Good for you. Good memory. Yeah. Dipromol is a type of antiplatelet medication that patients will be on for long-term treatment. Carbamazepine is an anti-seizure medicine that was also treated sometimes for neuralgia, or sometimes it's given also for certain psychiatric disorders. So when we're giving our adenosine to these particular patients, those medications will potentiate the effect, and as a result, potentiate also the side effects of that. So we want to cut our first dose in half. Let me ask you a question, Alexis. If you decide you're going to give a second dose, would you give the full dose, or would you cut that in half as well?
I would assume you would have to cut the second dose in half as well.
I love being around smart people. Yeah, you're exactly right. So it's going to be half the dose as far as we're moving along through that. Okay, excellent. All right, Mr. Youssef, this is yours. What should you do in VFib, pulseless VTAC, following the first unsynchronized shot? A, administer epinephrine 1 milligram IV push. B, immediately resume CPR. C, give amiodarone 300 milligrams IV push. Or that should be D, I'm sorry, perform a pulse check.
Resume CPR.
So let me ask you a question before I show you the right answer. You've got resume CPR. Why would we not just jump in there and give epinephrine right after the defibrillation?
We want to keep our chest compression fraction higher than 80. We never delay compressions.
Yep, exactly. So we've got to get that blood circulating, because keep in mind, in VFib, pulseless VTAC, there's no blood that's moving at all. So when we defibrillate that, even if that patient were to convert out of it, the contractile force of the heart is not going to be strong enough to circulate the blood. So we want to go in there and we want to help. We want to kind of prime the pump as far as we're moving through. Excellent, Youssef. Good job. Bella, O2 sat levels should be maintained at what value during the post-cardiac arrest phase? 92 to 98%, 90 to 95%, greater than 97%, or greater than 90%?
92 to 98%.
You guys are spot on here. Yeah. So with this, and again, don't worry about it if you're not getting your O2 sats up to 98, because again, keeping that O2 sat kind of down at the 95 to 94% is actually pretty good for your patient. And so that's going to be sufficient. Here's the other thing to keep in mind, guys, when you are working on your patient. Your O2 sat and your end-tidal are two very, very valuable tools, but they measure two different things, and they measure it in two different time levels. Understand that the measurement for your O2 sat tells you what the O2 sat was between 3 to 5 minutes ago. Okay. Your end-tidal tells you what your end-tidal was within the last 5 to 10 seconds. One is not better than the other. They're just different. So we got to know the limitations and the benefits of putting both of those together. Great job, Bella. Alexis, which of the following antiarrhythmic medications should be considered alongside vagal maneuvers for regular narrow complex tachyarrhythmias? A, atropine. B, ativan. C, amiodarone. Or D, adenosine.
Adenosine.
Yeah, adenosine is the one that we are going to utilize for narrow complex tach. Now, Alexis, let me ask you a question. What's going to happen if you are looking at a rhythm and you're not entirely sure as to whether this is a narrow complex or not, and you give adenosine when in reality it's a VTAC. What's going to happen to your patient?
I mean, it would just slow down the rhythm enough so that you could see what the actual rhythm is and treat it, but I don't think it would hurt them any.
Nope, it wouldn't hurt them at all. And in most cases, it'll have no effect whatsoever. So this is an important thing to remember. We can utilize adenosine as a diagnostic tool because there will be times that you'll look at your rhythm, you'll go, well, it looks like it's narrow. Well, no, now over here, it looks like a little bit wider. And you're not entirely sure as to which one it is. So give them at 6 milligrams of adenosine. Again, tell them what's coming as far as the side effects. And if you see a slowdown and then a pick back up, then that gives you a pretty good indicator that that's going to be a narrow QRS. That's going to be an SVT as opposed to a VT. Okay, ventricular tachycardia. Hey, Allie, welcome. Glad you're here. So we're just kind of going down the line, and each one of us is taking a question. You'll be up after Yusef. What's the purpose of targeted temperature management? A, protect the brain and other vital organs. B, keep the heart in a controllable rate. C, improve the effectiveness of medications. Or D, reduce the chances of reoccurrences of cardiac arrest. Yusef?
A.
Yeah. So how aggressive, Yusef, do we get pre-hospital wise as far as trying to cool our patients off?
We're not really going to get that target range of 32 to 36 degrees Celsius pre-hospital, but we should try to start initiating it before arrival at the hospital.
Yeah, some facilities are carrying cooled IV fluids so that you can begin that process. There were some people who were using cooling vests, but those have kind of gone by the wayside. So for the most part, basically what we're looking at would be we'll kick the AC up in the back. We'll try to find the coolest IV fluids that we've got and go that route. For our perspective, for our treatment is that we want to maintain that ROS and to keep the patient from going back into arrest. But the bottom line there is in particular to protect the brain cells. All right, Allie, this one's yours. For which of the following is transcutaneous pacing usually contraindicated? A, third-degree heart block. B, pulseless electrical activity. C, second-degree block. Or D, symptomatic bradycardia.
B.
B is correct. So now, Allie, you tell me what pulseless electrical activity is. What is PEA?
Basically you see like doesn't necessarily have to be, but like an organized rhythm that you would a lot of times you could be able to shock, but there's no pulse.
Perfect. And so, Allie, what is our treatment modality for PEA? What do we do?
Resume CPR.
And what else?
You can give epi.
And what else? One more thing.
One more thing. I don't know.
All right, let's phone a friend. Somebody help her out. What did I say the third thing was a minute ago? For PEA and asystole.
Is it airway or fluids or anything?
That's actually part of your reversible. I mean, part of your CPR. Reversible causes. Okay. So, guys, this is really, really important to remember that. And in particular, reversible causes also come into play if your patient is not converting out of a rhythm. So, if you've got a patient in persistent VTAC, persistent pulseless, persistent VFib, persistent VTAC, asystole, PEA, once you've gone through pretty much your first round of all the drugs that you're going to give, and then PEA and asystole, basically we got one drug that we're going to give, then we're immediately going to begin looking at the most likely causes of that PEA and asystole based on your scenario. So again, CPR, epi, PEA. Our reversible causes. All right, Bella. Which drugs are involved in the bradycardia rhythm? Atropine, epi, and dopamine. B, atropine, norepi, and dopamine. C, atropine, lidocaine, and adenosine. Or D, atropine, epinephrine, and lidocaine.
A.
Yep, you're exactly right. A, okay. So atropine, if it doesn't work, then we can go to dopamine and or epinephrine, okay? Primarily the reason for the dopamine is what, Bella? Because the dopamine doesn't really speed up the heart as much as it does what?
I mean, it's a pressor, so it helps with hypertension that's associated with bradycardia.
Bingo. So basically what it does is it's kind of a safety net there that says we know we got a slow heart rate, so we're going to try to increase that heart rate. Atropine may or may not be working the best in that regard, but then we can cause vasoconstriction to increase perfusion. Excellent. Okay. Alexis, PEA secondary to hypokalemia is most prominent in what patient group? A, individuals with diabetes mellitus. B, individuals experiencing chest pain. C, individuals with a history of hypotension. Or D, individuals using diuretics.
Would it be D?
Yeah, it would be D. Okay, so when we're looking at this, Alexis, why would a person, first of all, tell me, what is hypokalemia?
Low potassium?
So why would a person have a low potassium from the use of a diuretic?
I mean, they're on a diuretic, so they'd be losing like fluids faster, which would cause them to also lose more potassium.
Yeah, you're exactly right. So as they're taking this this diuretic and they're urinating, and especially if it begins to increase, now we run the risk of losing that potassium. Now, Alexis, let me ask you a bonus question here, and this wouldn't be a question that you would see on a ACLS exam, but you might see it on your cumulative exam in 362. Do you have the same problem with diabetes mellitus or a similar problem, and why? Or why not?
I mean, I would assume you would have the same problem, but I'm not sure exactly the specifics on why.
Okay. Can somebody help her out? Now, again, the question is asking most prominent here, and that's why the diuretics comes into play. With a patient that has diabetes mellitus, why also might we want to definitely put them on a monitor, but potentially even run a 12 lead to watch for hypokalemia? Yusef.
Because whenever their sugar is high, they have an increased urine output to try to get rid of that and normalize their blood sugar. With the increased urine output, you have increased electrolyte loss.
Perfect. Yep, you're exactly right. So again, especially the higher the blood sugar goes, the greater the fluid loss is going to be. In addition, not only will they lose fluid through urination, but they will vomit as well. And because of that vomiting, they're not going to be able to take much back in orally. So, one of the things is that, we encourage people to do is to try to replace those electrolytes as far as they're going through there. But if they can't swallow and keep anything down, then now we're going to run that risk. Allie, I got your hand up. Good.
So in that circumstance, if we're trying to rehydrate from the loss of fluids, would we pick LR or normal saline?
Well, you tell me. Which one would you pick and why?
Well, I was thinking LR, but I don't know.
Well,
Just to replace the electrolytes, but at the same time, I don't want to send anything else out of balance because it's already all out of whack.
Well, now think of it this way, okay? You are correct. It is going to be out of balance. But do you think that they're also going to be losing other electrolytes because of their vomiting and diuresis?
Yeah.
What electrolytes would be replaced if you use normal saline?
None. Well, sodium.
Sodium chloride. Okay. Yeah. But we're looking here. Remember, having a low potassium can cause your patient to go into cardiac arrest. So that's a critical lab finding there. So your thought about using the LR is perfect. Now, we know that there's not going to be enough in the LR to replace the electrolytes they need. But what it might do is, number one, is that it'll replenish their hydration, so they get more fluids in. And number two, it might just keep them, particularly in that area of electrolyte imbalance, from tipping over here where it would begin to now come in and cause some problems and some issues. Usus is one of those treat will keep your patient first, since diabetics typically have decreased renal function, for which LR is typically contraindicated for. Absolutely. Absolutely. So here's the thing. Again, if they have decreased renal function and they're not yet on dialysis, then yeah, we want to kind of keep that in mind, because LR can be slightly toxic to our patient's renal system. But again, a low potassium can often be permanently toxic if we put our patient into, or if we allow our patient to go into cardiac arrest, because in that situation, everything that we do is typically not going to work. Why? Because the main problem is a low potassium. Allie, do you have anything else?
No, that was it.
Okay, good. Alexis, was that your question? I lost track. We got into a discussion. I love it. So, Yusuf, I think this one's your question. If not, it is now. Your cardiac patient's rhythm reveals a normal QRS complex, normal P waves, and a PR interval of 0.28 seconds. Which of the following is characterized by these findings? First degree heart block, secondary type 1, secondary type 2, or third degree heart block?
First degree.
Yep, first degree heart block. Okay, long PR interval. Yusuf, what might be? Let me back up. If the PR interval were expressed in milliseconds, how would this be written out? How would this be printed on your paper?
It'll say 280 milliseconds.
Yep, 280 milliseconds. Excellent. Good. Okay. Allie, this one's yours. Here we go. Here's the opposite one. Assuming you're using a biphasic defibrillator, what's the initial energy dose for a patient in VFib or pulseless VTAC? 90 to 110 joules, 150 to 220, 180 to 240, or 120 to 200?
D.
D is correct. Okay. Now, again, Allie, I think you joined after we had this discussion. You probably see a question about this on your ACLS exam. I have not looked at the exams. I purposely did that because I didn't want to unconsciously put questions on here that's from the exam. What's the difference between a monophasic and a biphasic defibrillator?
The electricity goes 2 ways versus 1.
Yep, goes 2 ways. Therefore, a biphasic defibrillator, you can use less energy and it's going to be more efficient. Good job. All right, Bella, which of the following would be most appropriate for a hypotensive bradycardic heart rate of 55 patient who has ST elevation and leads V1, V2 and chest pain so that he can get nitro and or morphine, atropine, dopamine, a fluid challenge, or an epidrip?
Atropine.
Yeah. So we're going to start with atropine. If that doesn't work, what are you going to go to next?
Pacing.
Yeah, very good. Very good. Now you could potentially, depending upon the rhythm, now you could indeed start with a dope drip or go with an epidrip to raise that up. Pacing is also going to be an option that you could bring into that patient. Okay, excellent. Alexis, standard treatment of angina pectoris includes which of the following? Nitro, furosemide, and morphine. B, furosemide, aspirin, and lidocaine. C, morphine, naloxone, and furosemide. Or D, aspirin, nitroglycerin, and morphine.
B,
B is in Bravo.
no, the aspirin, nitro, and morphine.
Yeah, there you go. Yeah, you're exactly right. We used to say Mona meets all patients with chest pain. We don't do that so much anymore because not all patients are going to get oxygen depending upon whether they need it or not. But definitely, these are your 3 drugs that you're going to do. Now, Alexis, of these 3 drugs, let's say that you've got your IV started. Let's say that your patient has a good blood pressure, so that's not going to be a problem. Which one of these meds should you give first?
The aspirin,
Why?
because you want to stop the clots from becoming any bigger.
I can't say about anybody else because I haven't done a review, but you 4 people are not going to have any problems with ACLS. This is good. Very, very good. Yosef, the primary decision point in the bradycardia algorithm is the determination of A, heart rate, B, adequate perfusion, C, blood pressure, or D, rhythm.
Let's say adequate perfusion.
Yeah, so basically this is important because this is going to be really, really critical to assessing your patients. We know that if we got patients that are in really good shape, they're going to have a low heart rate, and they're going to have a low blood pressure as well when they are resting. Other patients may have a low heart rate, but compensate for that with an adequate blood pressure. So the thing that we're looking at as to whether or not we're going to treat our patient is this right here. Now, Yusuf, other than just simply looking at the blood pressure, what would be some things that you would be able to assess on your patient to determine whether the perfusion is adequate or not?
Mental status and skin color.
Perfect. Yep. And in that order, okay? In that order. Look at their mental status and their skin color and condition. Very, very good. Allie, this one's yours. Which of the following would be most beneficial for a patient with acute congestive heart failure? Vasopressors, furosemide, diltiazem, or CPAP?
B. D.
Did you say B, Bravo?
Yeah, I did. I
What-
was trying to decide between the 2.
What is furosemide?
I don't know, maybe I got it mixed up, but doesn't it help you get rid of excess fluid?
Yeah, it's a diuretic. You're exactly
Okay,
right.
that's what I thought.
It is Lasix. Usually it's got ABCs. Yeah, you're right. So
Yeah.
you could potentially go with Lasix, okay, when you're a little further down. One of the things that works pretty well is going to be the fact that CPAP is really, really good for our congestive heart failure patients. So, Allie, you teach me, why is CPAP pretty effective in reversing congestive heart failure?
The positive pressure helps push the fluid out of the lungs.
Very good. Yep, you're exactly right. All right, Bella, your patient has a history of SVT. Patient now has a narrow complex tachycardia rate of 180, pulmonary edema, BP is 70/40, and is unresponsive. Which of the following should be your initial treatment? A, Lasix to treat the pulmonary edema. There you go, Allie, which is what we said. B, dopamine to activate the alpha receptors. C, dobutamine to raise the blood pressure. Or D, synchronized cardioversion.
Synchronized cardioversion.
Yeah, you're exactly right. I mean, we've got a patient here that is circling the drain. Fast heart rate, low blood pressure, pulmonary edema, and unresponsive. So this patient is definitely in decompensated shock. Okay. And they're knocking on the door of irreversible shock. Can we give them Lasix to treat the pulmonary edema? Yeah, we can. But again, if we get the blood pressure up and we slow the heart rate down, that pulmonary edema will probably take care of itself. We could potentially give dopamine if we needed to here. So that might be a secondary line of treatment. But the big thing we got to do here is we got to slow this heart rate down. Now, Bella, let me ask you a bonus question here. Why is this patient in shock as a result of a heart rate of 180? Tell me what's a mechanism that's causing that?
It's because the heart rate's so fast, it can't like adequately push out blood, like because the contractions aren't being like fully like contracting, I guess. So it has a decreased like cardiac output, which therefore will lead to inadequate perfusion because blood can't perfuse the organs that it's trying to push out.
I'll give you 95% of that answer. Let's go for 100. Why does the heart rate have a deficit on the cardiac output here?
Because it can't contract all the way and decrease preload.
There you go. You said the magic word, decreased preload as far as what's going in there. All right, Yusuf, good. Thank you. Thank you. All right, Alexis. You're treating a patient with the indicated 3-lead ECG that you see at the top of the PowerPoint. Patients complaining of severe chest pain and severe shortness of breath. Vital signs are pulse too fast to count, respirations of 24, BP 110/70, and pulse oximetry of 92. You should, and this is one of these kind of like registry questions, select all that apply here. So what would you select?
I would select A, C, and D.
A, C, and D. The right answer is indeed A, C, and D. Now let me ask you a question. You've got your IV started, all right? With this particular patient, if you're going to cardiovert your patient, do you have time realistically to give them sedation in this particular scenario? And are they stable enough for sedation? So 2 questions. Do you have time? And number 2, are they stable enough?
I think if you were quick enough, you could consider the sedation? Because, well, I guess it would depend on their mental status. It doesn't really say anything about their mental status. That would be a big factor for me on if I would, but their blood pressure is fine, their pulse ox is fine. The respirations are a little fast and the pulse is obviously fast. So to me, it would depend on the mental status.
Okay, so you have a little bit of information about the mental status in here when it says the patient is complaining. So to complain means that I have to give you a verbal report in there. Okay, so Yusef says never delay cardioversion. So Yusef, I'm going to take kind of the opposite side of that. Is I would tell you, in this particular situation, you probably do have time to give your patient a little bit of sedation. My choice of sedation in this would be ketamine because it does act rather rapid and it's not going to have as much of a direct negative impact on your patient's blood pressure as, say, like maybe Valium would. So in my opinion, but that's the nice thing about medicine is that you can have varying approaches to this. But I would say in this particular, yeah, ketamine is right. In this, I would tell you, if it were me, I would really appreciate it if you would help me not to remember what you're about to do to me. Now, if the blood pressure was like 70/40, you can apologize to the patient after you've saved his life because of the pain that you've caused. All right. Yusef, this one's yours. If a patient is experiencing a tachyarrhythmia, if a patient experiencing a tachyarrhythmia becomes unstable, what's the most important intervention to consider? I think we've kind of already gotten this one, but go ahead, Yusef, what is it?
See,
Yeah, so basically we want to go with synchronized cardioversion, okay? Guys, when you are doing your both your written and your mega code on tomorrow, make sure that you're able to differentiate between defibrillation and cardioversion, okay? And so again, I would encourage you to probably use the term synchronized cardioversion. If you were to come through my station, if I were testing you and you would just simply tell me cardioversion, that's going to be okay for me because I know you know the difference between cardioversion and defibrillation. But again, with your exam, make sure that you watch those as far as the terminology. Allie, go ahead.
Okay. I heard you talking about this when I first joined, but you're talking about the difference between VTAC and SVT.
Okay.
If they're like so unstable that you're like, I need to use electricity and you can't differentiate it, which one do you go with?
All right, you tell me.
Do you cardiovert or do you defibrillate?
Yep. So you're the paramedic. You make the call, and then I'll kind of chime in with my route.
Okay. I would synchronize cardiovert
Why?
at a higher level of electricity.
Okay.
Because
So
syncing it with VTAC is not gonna it's not gonna cause any harm to the patient.
So let me throw this out for the whole group. It's a good discussion point. If you have a patient with VTAC with a pulse who is unstable, do we synchronize cardiovert that patient? Oh no, you guys know this. Jump in here and tell me.
yes,
Yeah. And what would be your dose, Yusef, that you would cardiovert your patient who is in VTAC with a pulse?
50 to 100 joules.
And what would be your dose for cardioversion for unstable SVT?
50 to 100 joules.
Yeah, so see, Allie, here the thing is with both SVT and with VTAC with a pulse, the bottom line here is preload is pretty much wiped out. So our patient is is becoming very hypotensive as a result of that. So basically what we got to do when they are symptomatic is we got to kind of wipe out all the impulses and allow the SA node to take over. In SVT, what we're doing is we're wiping out all of those atrial impulses that are coming down. If we're not entirely sure if it's SVT or VTAC with a pulse, cardioverting the patient, if they are symptomatic, is going to be the treatment for both of them. Okay. Where we want to try to make the differentiation is going to be if they are not yet symptomatic. Okay. And so if we've got VTAC with a pulse, Allie, and the patient is not yet symptomatic, what would be your options as far as medication treatment?
I heard you guys talking about adenosine just to be able to differentiate the two.
But yeah, that's if you're not sure. But let's say you're looking at this and you go, "Oh yeah, that's VTAC with a pulse." I have no doubts about that whatsoever. Patient's got a fairly good blood pressure, so we're not inclined to go with electricity just yet. What options in medication do you have to treat that?
Amio at 150 every 10 minutes.
Yep. So amio would be your most logical choice. Keep in mind the back of your head, you can use lidocaine. Lidocaine's an old drug. It's been around since the dawn of time. It has fallen out of favor with AHA, although it is still listed as one of your options, and it's also still listed in the listing of drugs in your red book. So again, amio would be the route that you would go. Does that help, Allie?
Yeah.
Okay. All right, Allie. This one's yours. After providing a shock with an AED, you should A, immediately start CPR, B, check a pulse, C, give a rescue breath, or D, let the AED reanalyze the rhythm for you.
A.
Yeah, we're going to start right up with CPR. Guys, probably I would say at least 10% of your exam will deal with basic life support in the area of knowing questions about CPR, rates, ratios, and things like this. So make sure that you're very, very good in that particular area. Bella, during CPR with no advanced airway in place, the compression to ventilation ratio is A, 5-1, B, 30-2, C, 10-1, or D, 20-2.
30-2.
30-2. Okay, 30-2. Understand when you stop to give those two breaths, all circulation stops to the brain and the blood literally begins to drain away from the brain. So it's going to take probably of your next go round of the 30 compressions, it's going to probably take the first 10 to 12 of those just simply to reprime the pump to get blood now to begin flowing through the brain again. That is why it's so critical that we minimize any types of interruptions. According to the ACLS 2020-2025 guidelines, PEA is defined as A, any unorganized rhythm without a palpable pulse, B, any organized rhythm without a palpable pulse, C, any organized or unorganized rhythm without a palpable pulse, or D, any rhythm without a palpable pulse. Let's see, I think this one's Alexis.
I would say C or D. I mean, I think they're saying the same thing.
Yeah, I got to go back. Once I put this up here, I worked on these yesterday, and now that I've got these up here, you're exactly right. C and D are basically saying the exact same thing. So I got to come back. I'm making a note here to rework this question. But yeah, you're exactly right. Technically speaking, VTAC or VTAC without a pulse and VFib are technically PEA types of rhythms as well. But now don't let that confuse you. we're primarily looking as PEA being more of similar to in a systole type of rhythm. USAF. 2 rounds of adenosine can be administered to attempt to convert a tachyarrhythmia to sinus rhythm. What's a recommended dosing of adenosine in such a scenario? 12 milligrams IV pushed, followed by 12 milligrams IV push if no conversion. 12 milligrams followed by 6 milligrams. 6 milligrams followed by 6 milligrams, or 6 milligrams followed by 12 milligrams.
D, as in Delta.
B is correct. So keep in mind that with these patients, again, we're going to start our IV as close to the heart as we can. We're going to use the largest gauge catheter that we can. This would be one of those times when I would tell you it's probably okay to use a 16 on a cardiac patient, just simply because we want to minimize the friction coming from the catheter. We want to go with the shortest catheter that we can, and we want to get that medicine as quickly as we possibly can as well. All right, ladies and gentlemen, that is my review for you. Basically, we've covered, from what I remember from last year, all the types of questions that you can expect to see. Now, we've got just a few minutes left. Do you have any questions or anything that you feel kind of worried about as far as either your written exam or your mega code that we need to discuss now?
Do you by chance know how many questions this is on the written part?
I believe on the written part, there are 50 questions, and you have to score an 84 or higher to pass the written part. One of the things I will do is I'll do a little bit of research, because it's been a while since I've taught ACLS, but I will find out for sure and just send you an email, Bella, and we'll let you know.
You're right. That's what Hillary says.
Okay. All right. So it is 50 and you got to score 84. Perfect. Anybody else?
The stroke algorithm.
Stroke algorithm. Okay. So basically what we're looking at here with stroke patients. So Allie, tell me, what are the 2 types of strokes?
Hemorrhagic and I don't know, I can't remember the other one, but it's just a blockage. It's just no bleed. I can't remember what it's called for some reason.
It's okay. It's ischemic.
Ischemic.
Yusef, of those 2 types of stroke, which one is the most common?
Ischemic.
Yeah, ischemic occurs about 80% more often than does hemorrhagic. And that's really, really good news, because we can do something that is relatively non-invasive for ischemic strokes, but there's really not much other than, if the patient survives, other than rehab to help them compensate for the damages. So basically what we're looking at here for our strokes is that we want to identify, first of all, when we go through, we want to do the Cincinnati Pre-Hospital Stroke Scale. Ask them to smile, to show you their teeth. Have the smile really, just a big, exaggerated smile, okay? Because sometimes you can have people that will have mild to moderate drooping, and when their face is just kind of resting, you may or may not notice that. But if you tell them, give me a huge, exaggerated smile, that's really going to use all the muscles that's in there. So if we see drooping on one side of the face, second of all, if we see arm weakness, almost always it'll be on the same side of the face of where the drooping is, if it's present. And then we want to find out as far as any type of speech problems. And we just simply use, you can't teach an old dog new tricks. Simply we use that because that's going to be the phrase that they'll use at the hospital, and they'll be able to compare that. Once you identified your patient has a stroke, there's 2 things that are critical for you to do. Number 1, determine the last time that patient was normal and without symptoms. Number 2 is to notify your hospital as soon as possible because they need to clear the CT scanner. You'll stop at the ER door for just a minute and you will take your patient straight back to CT. Stay with your patient. They're going to put that patient back on your stretcher, and now you will bring the patient back into ER for treatment. If your patient has a stroke, basically what we're looking at here is supportive care. Monitor IV O2, okay? If you feel like that your patient has, in addition to this, a low blood sugar, do we give concentrated dextrose to these patients? And if we do, why? And if we don't, why?
We wouldn't give glucose unless we've checked it. But you're not going to give a stroke patient glucose because it will, well, in a hemorrhagic stroke, it can eat the tissue because it's necrotic.
Well, yes, and most of the times, you said we're able to identify whether the patient has a hemorrhagic stroke, but there's sometimes we look at our patients and we're not entirely sure. So the protocol for glucose is if the glucose level is less than 60, and to be quite honest, guys, my personal preference is less than 55. Again, because just what Yusef said, I really don't want free glucose, concentrated glucose coming into contact with the brain tissue just because it's so very necrotic. So that's the big thing that you want to remember about your strokes. Cincinnati pre-hospital stroke scale, identify the time that the patient was last normal, call in a stroke alert for your hospital, and know when and when not to utilize glucose. Does that help you, Allie?
Yeah.
Any other questions? I'm really not in that big of a rush. I've got some time here. All right, hearing none, I'm going to convert this video. I will post it in Blackboard under your 305, and I'll send the link out to y'all and to everybody in your class. Between now and tomorrow, if you think of any questions you might have, typically I get into the office at about 7:30. Come by the office, grab me, and let's talk, okay? Because I think everybody's going to be okay in ACLS, but I definitely before a year aren't going to have any problems. So again, if you need something, email me today. If you want to come in and chat with me before your class tomorrow, I'll be here early in the morning. Okay. Y'all go out, enjoy. The sun is shining. It's still a little cold, but stay warm. Okay.
Thank you.
See y'all.
Thank you.
Thank you.
Bye-bye.
you.